my topic will be about tendon transfers. And there are several options for non-repairable rotator cuff tears, as we know. And I will be focusing on the latissimus dorsi transfer in these transfers. First of all, I would like to do some definitions like my colleagues. First of all, massive rotator cuff tear means rupture of tendons more than 2, and retraction of the tendon must be more than 5 centimeters. And these tears includes 30 to 40% of all tears. And atrophy and fatty degeneration are really important issues. And the most important thing about these massive tears are re-rupture rates may be up to 70%. And what about non-repairable tears? When we cannot make any repair? According to Gerber, excessive tension during fixation, at 60 degrees of abduction means non-repairable rotator cuff tears, and these tears include 12% of posterior superior tears. And I need to make a definition about the pseudoparalysis. As all we know, chronically, if the abduction or elevation is less than 90 degrees, we call it the pseudoparalysis. And this is important because of the tear involvement. In type T tears, according to Colin, we only see 3% of pseudoparalysis, but this ratio increases up to 33% in type E tears, including teres minor. And if you look at the examination, external leg sign and hornblower signs are important, and especially if you have a teres minor tear, you can see a hornblower sign. X-ray is another important issue. We see a superior migration of the humeral head, and the acromiohumeral distance may be less than 7 millimeters, and this means an infraspinatus tear in these kind of X-rays, but we cannot get standard X-rays every time. We must be careful about that. Acromion erosion is another X-ray sign, and acetabolization shows us a strong predictor for non-repairable tears of the rotator cuff. If we look at the MRI, as you see here in Gawhale 3 and 4, 43% of these tears are non-repairable, but this ratio decreases just 6% when you have a Gawhale 0, 1, or 2. Tangent sign is another important view in MRIs. If you have a positive tangent sign, then you can have a 30% of non-repairable tear, and this ratio decreases to 6% when you haven't a tangent sign. While doing a decision, age, tendon quality, retraction, implant cost, and experience of surgeon are really important. After these evaluations, MRIs, X-rays, we need to consider these things. What about the ideal patient? We can give an answer to this question. For example, if you have a high demand patient and with an intact subscapularis, and if you have an external leg sign, and if you have a 90 or 100 degrees of abduction, you can be an ideal patient for latissimus dorsi transfer. You mustn't be a pseudoparalytic, and if you have a failure after rotator cuff surgery, you are also a really good ideal patient. When do we avoid from this surgery? If you have a deltoid insufficiency or axillary nerve deficit, if you have a subscapularis tear, advanced arthrosis, or frozen shoulder, these are contraindications for this kind of surgery. Teres minor tear or fat degeneration is also a relative contraindication for latissimus dorsi tendon transfer. I would like to give some words about the latissimus dorsi. It's an internal rotator, as all we know, and also it's an adductor of the shoulder. And thoracodorsal artery and nerve supplies this muscle or nerve tendon. What's our goals? What are our goals according to biomechanics? The most important one, to maintain posterior force coupling and also to gain external rotation with active contraction. Tenodesis effect is also another important issue to depress the humeral head. And also this transfer, latissimus transfer, acts like a fulcrum for the deltoid support, as you see in this schema. Firstly, Gerber in 1988 performed this surgery and performed this study for non-repairable posterior superior rotator cuff tears in 14 patients and had a 80% of good or excellent results for the patients with external rotation deficit and abduction deficit. In 2006, also Gerber made another study with 69 patients with a mean follow-up of 52 months, and they found inferior results in patients with teres minor fatty degeneration, and if you have a subscapularis insufficiency, also they had inferior results. Warner also answered this question: do we do a primary surgery or a salvage tendon transfer for these patients? If you do a salvage reconstruction, you can have inferior results when compared with the primary, with a less satisfaction and functional scores. Also, we may have some complications like deltoid rupture and latissimus dorsi re-ruptures. I would like to show you two patients. This patient is 52 years old with a rotator cuff tear. We performed a repair, as you see in this video. This is the index surgery. And he was a really heavy smoker with 3 packages of cigarettes daily. After this surgery, after 5 months, 5th month, he came back with a re-tear with the impaired overhead function, pain and external leg sign. This is the MRI. And we performed latissimus dorsi tendon transfer for this patient. You see the technical details here, Krakow sutures. And this was the pedicles. There mustn't be no tension on pedicles, as you see here, with a careful dissection. And the tendon excursion is also important. It must be between deltoid and triceps muscles. And you see the insertion site here on the right up. The footprint must be closed up to subscapularis tendon. And you need to use these kinds of slings for a while after the surgery. This is the post-transfer, latissimus transfer, 4.5 months. As you see here, he has a supple range of motion with full abduction, and he has no external rotation leg sign here. I would like to give you another patient example. He was a 46 years old patient with a rotator cuff tear. In an outer center, they performed the rotator cuff repair. Here you see the anchors, and he came us with an abduction deficit and a significant external leg sign. The position is semi-lateral decubitus, as you see here. We used the Krakow sutures again. We also used latissimus dorsi and teres major for the reinforcement of the tendon transfer. It's not necessary, but you can also add teres major for the reinforcement. After 3.5 months, on the left side, as you see, this patient has still some problems with abduction. But on the right side, as you see here, when he triggers his latissimus dorsi transfer with a J maneuver, he can abduct or elevate his arm easily. These patients must be educated about this J maneuver. As I described before, the latissimus dorsi is the internal rotator and the abductor, and we are aiming to abduct or elevate the arm with the triggering the adduction position, starting with the adduction and finishing it on abduction. As a summary, latissimus dorsi is a good choice for non-repairable tears on suitable patients, but careful dissection and technique must be carried out, and proper rehabilitation is mandatory after these kind of surgeries. Thanks.